All right. Hi, everyone. Welcome back. Our second asthma talk, focusing more on immunotherapy, is next, and also covering other aspects of immunology in lung disease. And that talk is coming from Dr. Medoff, one of our esteemed pulmonologists and immunologists here. Dr. Medoff?
Great. Thanks so much, Angie, and welcome, everyone. Great to be talking to you. I've done research in lung immunology for now close to 30 years, actually, believe it or not. And what I'd say is really most exciting is in the last 5 years, we've really seen just a revolution in terms of what we can do in terms of manipulating the immune system as a way of therapies. And I'm sure you all are familiar with the use of immunotherapy in cancer and asthma and now COPD. And so this really is meant to be kind of a broad overview of all those different therapies. I'm assuming you've had some of this touched on in the other talks. So we're going to sort of rapidly move through a bunch of these different therapies, talk about the use of the immune system as in the therapeutic landscape, and cover all these different aspects. And hopefully be of interest to all of you. And as this field continues to expand, provide a basis for kind of evaluating these future therapies. With that introduction, I just do want to disclose a couple of aspects of my work. I have served on advisory boards for both Sanofi and Regeneron, the makers of dupilumab. There are a few slides of dupilumab in this talk. I've tried to keep everything as objective as possible. I also have sponsored research agreements from both Sanofi and Regeneron, and do some work for Draper Labs that's unrelated to this, and have most of my funding through the NIH. And so what we're going to do today is review the basics of the immune system. I think we really have to understand how the immune system works, to understand the use of these new drugs, and how manipulating the immune system works for diseases, especially lung diseases. And then, of course, we'll dive into specifics of immunotherapy in lung cancer, asthma, and now COPD as the kind of new area where these are being used effectively. So what is immunotherapy? I think we have to define this. It means treatment of disease by altering the immune response. So we're not treating the disease directly. We are treating the immune response within the body to affect that disease. And that can be done in lots of different ways. You can induce an immune response, sort of something that's not being recognized. We want the immune system to recognize and then effectively clear it. You can enhance immune response. This is what happens in most cancer therapies now, where we're enhancing the already existing immune response to tumor antigens. Obviously, we can suppress the immune system. We've been doing this for years and years with steroids and other drugs. It's just our ability now to do that more precisely is kind of the new ways that we're approaching these things. And then you can change the way the immune system reacts. And this is being utilized in all types of systems where it's thought maybe a Th2 response may be dangerous or lead to poor repair, and then skewing the immune system in a different way, allowing repair or clearance of pathogens, etc. And, I think as you think about it, this is nothing new, right? We've had lots of things that have used the immune system as therapy. We've activated the immune system with vaccines for years and years and years, very effectively. There is a long history of activating the immune system in cancer. Back in the 80s and 90s, people tried IL-2 and interferons to kind of get the immune system active against cancers with some success. And then, of course, for years, we used to activate the immune system to clear hepatitis C virus and other things with interferons. These were, of course, not very specific and had lots of side effects and other issues and weren't particularly effective. And the new therapies are just much more targeted. And then we can suppress the immune system in autoimmunity. Allergy, asthma, obviously, is one that you all may be particularly effective with. Transplant, we've suppressed the immune system for a long time. So what's really new is the ability to be much more specific, much more targeted in what we're doing. And that involves multiple agents. It's interesting to think that omalizumab has actually been out for 25 plus years now. Still very effective, still used in asthma patients, but this was really one of the first biologics that were used where we were targeting an antibody, IgE, which is obviously pathogenic in allergic diseases, and was effective in asthma. It's now recently been approved for food allergy and other processes. So still studied, still effective, targeting one specific aspect of an allergic immune response. More recently, we've had therapies that target cytokines. Mepolizumab was the first one to do that, targeting the cytokine IL-5, which is important for eosinophil formation and survival. And effectively, if you give drugs that target IL-5, you eliminate all eosinophils very effectively in most patients. So here we're, obviously thinking in asthma, also hypereosinophilic syndromes, where you have this eosinophil that's an effector cell causing disease and clearing it by just taking the growth factor, or the factor that causes them and has them exist in the body. We can target T cells and dendritic cells, and this is done with the cancer therapeutics called immune checkpoint inhibitors. These are targeting proteins on these cells that actually suppress their activities through PD-1 is the most common, but there are other ones that are LAG-3, TIM-3 that are either approved or in development. And these drugs activate an immune response against tumor, and as you know, have been incredibly effective. I mean, if I think about in the last 20 years, how much better we are at treating melanomas and lung cancers, it's really due to these drugs in large part. And then we won't talk about it today, but there's actually taking immune cells, altering them, and putting them back into people to target specific tumors, and CAR T cells has been incredibly effective for that, especially in certain lymphomas and other cell types where you can target a specific cell and make that cell sort of activate that cell, and then there are kill switches, et cetera. Pretty sophisticated functions here. So that's what we're doing with immunotherapy. And to understand that, I think we just need to step back for a second and think about the immune system. And I put this slide up here, not so much to make a joke, but as to remind everyone that although I think most people think of the immune system as important for just defense against infections, really the immune system is all about organ homeostasis. So the immune cells that exist in your lung, your pancreas, your gut, et cetera, are there just to maintain a functioning organ. And that, of course, includes defending against an invading pathogen and infectious agent. For sure, that's one of its most important jobs. But it also means maintaining the organ functions by clearing dead cells, clearing abnormal cells, whether they're tumor cells or just cells that are slightly affected, clearing unneeded proteins. So macrophages in the lung clear surfactant, right? If you have an abnormality with that, you develop alveolar prognosis. In the heart, if you get rid of macrophages, you develop arrhythmias. So they're maintaining the regular sort of conduction system that exists in the heart. So cells of the immune system are more than just defense against pathogens. They're really about organ homeostasis. And that's why they're so important in things like cancer and asthma and other disorders where there's some aberration in this immune system that either is allowing a tumor to grow or causing inflammation to relatively harmless antigens in the case of asthma. So thinking about it in that way, I think really helps with understanding some of these immunotherapies. Now, stepping back even further, thinking back to your college, med school, or other graduate school training, a bit about the immune system. I think you just have to understand the real basics of this. And there are two arms to the immune system. There's an innate arm, which is really that first response. It's quote unquote non-specific. We now know there is some memory involved in this, but for the most part, you're talking about that initial reaction, minutes to hours, from some sort of insult. And that includes barrier functions like the epithelium, preventing things from leaking into the lung or leaking out of the lung, cellular cells, myeloid cells, macrophages, monocytes. There's innate lymphoid cells that exist within the airways that are important for initial responses. And of course, granulocytes, which can be brought in within hours into sites of infections or injuries. And then there's also proteins that's complement, that's surfactants, other proteins, macromolecules that can stud invading organisms or other things like that and mark them for clearance. And then really important second arm is the adaptive arm. And this is the specific arm of this second line. It develops hours to days later and then provides long-lasting memory to whatever insult. So once you get a certain infection, you now have ongoing immunity to that infection as long as it remains roughly the same. And that involves cells of predominantly T cells, as well as B cells and antibodies being the major mediators of that. Innate systems, really important for that initial response. For the most part, we're manipulating this adaptive memory response when we're manipulating the immune system, though, in these immunotherapies, because that's, when you develop asthma, you are sensitized to an allergen, and you are going to react to that allergen again and again because your immune system remembers that. And so targeting this adaptive arm really leads to the long-term changes we hope for the most part. But there are things that obviously target these aspects of it. And there's a lot of interactions in both of these. And, if you think about the lung specifically when it comes to the immune system, the lung is one of 4 mucosal immune sites, along with the gut, the GU tract, and the skin. It is unique in a couple ways. One, it has a massive surface area, not quite of the gut, but more than the skin and the GU tract. It has a huge environmental response. Basically, every breath, you're bringing in all types of pathogens, toxins, etc. And so the environmental exposure, it's like 11,000 liters a day of all this stuff that you're constantly breathing in. And then it also has a massive systemic exposure, right? Your entire circulation goes through the lung at the same rate as the rest of your body. So whereas the gut and the kidneys, et cetera, may only see 10, 15% of the circulation, the lung gets 100%. So if you have a leg infection, the lung is seeing everything that's there. It's really literally bathing the lung in those type of mediators. So not surprisingly, the lung has a pretty extensive immune system that has to work both on the systemic side as well as the mucosal side. That involves a bunch of innate cells, including the epithelium, which is an active, it's not just barrier, but also secretes all types of mediators that can activate the immune system. And, mast cells, macrophages, dendritic cells, eosinophils, neutrophils. And then also has these very prominent adaptive components, not just lymphoid tissue that exists within the lung, but lining these cells, the airways and other sites are B cells and T cells. And when you have pathologic processes, asthma, COPD, these aspects get augmented. So you can find big colonies of B cells and T cells in the airways in COPD and asthma that are there to sort of respond to toxins and other mediators. And there's all types of interactions between these two that gets pretty extensive. So with that, we're going to dive in and fly through a couple diseases. There's a lot to cover here, so I'm going to move a little fast, and I think I'll be here for the evening Q&A if people have specific questions. So why is cancer and the immune system so related? Well, the main issue, as I mentioned, is that the immune system really is important for surveillance of abnormal cells, and thus can limit tumor development. Tumors really incite an immune response because they are non-self or altered self. This involves both innate and adaptive immunity. And how do we know this? Well, if you immunosuppress people, there is a higher incidence of malignancies. You see that in HIV, you see that in transplant patients. If you look at tumors, there's often immune infiltrates around the tumors. Some tumors, like pancreatic cancer, develop fibrous shells around it that seem to shield it from the immune system. Others suppress the immune response. That's how tumors escape. And then, of course, the paraneoplastic syndromes we see, polymyositis, dermatomyositis, that are often associated with cancers, probably are from immune activation by the tumor that then spreads systemically and causes these autoimmune type disorders. So, a lot of aspects point to immune system being important for prevention of cancer. And then, of course, the reason we get tumors that exist is that there is this immune escape that can occur through these immune checkpoints that we now can target with great efficacy in cancer. So the way the immune system should work and should limit tumors is you have your abnormal cells that start to proliferate. There's antigens released from these tumors or picked up by other cells. A dendritic cell or other antigen presenting cell can then take that up, put that on your MHC for antigen presentation, and along with a second signal shown here as B7 that feeds into T cells, so CD28, activates tumor-specific T cells. Here's CD8 T cell that then can migrate to the tumor, recognize the tumor here as having the antigen being presented here, and then kill that tumor with perforating granzymes, various cytokines. T cells can join in on this. CD4 T cells can go in and help with this, and that should then limit or eliminate those tumor cells. What seems to happen, however, is tumors take advantage of various checkpoints in the immune system that are there to really limit immune activation. So if you get a viral infection, you don't want your immune system so engaged that it kills off all your epithelial cells because it's trying to kill the virus. So these systems exist as kind of checks to reduce the inflammation once you've cleared a virus. And tumors take advantage of that. And they can do that through a mechanism through CTLA4, which blocks that second signal that is needed for T cell activation and can lead to T cell inactivation. Or the tumors can express PD-L1, which is a natural inhibitor of T cells, which binds through the receptor PD-1, leading to T cell inactivation, or what we call T cell exhaustion. So if you block these agents with ipilimumab or the anti-PD-1, PD-L1 therapies, you activate these T cells again so they can go on and kill the tumors. And that's effectively what's happening with these therapies. One of the first of these, and still used a lot, is nivolumab, which is an antibody against this PD-1 that's on T cells, has been approved for quite some time. And, this probably was covered in the lung cancer talk, but there's been all types of therapies now. This is one of the original studies that looked at its use in non-small cell lung cancer in people with advanced who had failed platinum-based chemotherapy, and it had this nice survival advantage. And we now know these drugs can be used first line, incredibly effective, improve survival, also in melanoma, renal cell carcinomas, and are used in a lot of different tumors, especially those tumors that are quite genetically different than the cell. When tumors are close, like adenocarcinomas, it doesn't work as well, but squamous cell carcinomas, things like that, these therapies can be very effective. Of course, there's a downside to activating the immune system. And, one of the things we see a lot, and Angie and I are part of this group that have now really focused on complications of cancer therapy, of which the immunotherapies are really one of the most prominent. And it's these immune-related adverse events that have been really the downside to these immunotherapies in cancer. And I think since many of you probably are seeing some of these patients, I thought I'd spend just 5-10 minutes on these aspects, because it's really a field that's, I think, growing with not a lot of data to support what we're doing in these things. So I'll tell you kind of which is a lot of this is just expert opinion, not so much based on any randomized trials or anything. The possible mechanisms for this, I think most of the time we're thinking that because the tumor is derived from self, you're activating a T cell against the tumor where it's often very effective, but that T cell cross-reacts with something in the body here. There's a myocarditis type process where there's a tumor in the heart, antigen in the heart that matches something in the tumor and leads to activation of that. You can also stimulate the development of antibodies, here showing that thyroiditis may result because you've stimulated antibody production against thyroid hormones. Often it's just increasing inflammation. You may get a viral infection. while you're on this. And normally the immune system would just react a little bit, clear the virus, and then quiet down. But because you have these therapies on board that activate the immune system, the inflammation is more intense, and you get this more impressive pneumonitis, colitis, etc. And then there are all types of other ways in which it may be stimulating or putting complement, because you have these antibodies forming on cells that then lyse actually regular cells here, causing a pituitary issue. So multiple mechanisms, we're not quite sure what's happening, but it clearly is an immune-mediated process that now is attacking normal cells rather than just the tumor cells. And, when you look at these, PD-1 inhibitors cause much more pneumonitis than the CTLA-4 inhibitors. It's about 4 to 5%, maybe even higher in these. And if you're on the combination, the incidence goes up to 10%. You can see this as quick as a month. I've seen a few people who had been on it, just received 1 or 2 doses and already have intense reactions. Often that's a good sign for clearance of the tumor, in fact. It's just unfortunate when it also attacks normal organ function. But there can be a wide range, even up to 2 years, and 6-9 months after discontinuing therapy, you can still see these things present. The drugs have very long half-lives and can be bound to T cells for months and months after the therapy's been discontinued. Not surprisingly, if you have lung cancer, you're more likely to have pneumonitis when you're treated with that. Renal cell carcinoma also has a higher incidence. We do see it in melanoma, but less likely. There could be 20% pneumonitis developing in people treated for lung cancer. And as I mentioned, there's reduced risk in adenocarcinoma, but it's also less effective for those groups. If you do have ILD, those people are at very high risk, 6 to 10-fold increased risk, and you really have to think about whether you need to do this therapy for patients who have an existing ILD, especially if it's an active process. Sarcoid, I've had a death from sarcoid for someone who we started who had melanoma. It just seemed like the best therapy, and just his disease exploded and he ended up passing away from it. So it can have a high risk if you have an existing interstitial lung disease. Pneumonitis really is one of the most feared complications, not only because it's common, but it's also pretty deadly when it occurs in severe cases. Really only myocarditis has a worse mortality, but that's much less common. This is not one that you want to play around with, and the oncologists who treat patients really are very concerned when they see someone developing infiltrates and cough and shortness of breath. The most common symptoms are dyspnea, cough, pretty nonspecific. Some people have fever, some people have chest pain, but up to 30% of patients are just picked up because they get screening chest CTs as part of their cancer screening, and there'll be some subtle ground glass on there. And that's always tough to know what to do, because often they're benefiting from their therapy. And you don't only see one disease here, right? You can see pneumonitis with colitis or joint disease and other things like that. So often when you have one immune-related adverse event, you have more. Unfortunately, there's no pathognomonic finding on radiology here. It can be all types of things, from organizing pneumonia, hypersensitivity patterns, ground glass, nonspecific type things. There's muscle disease. There are these sarcoid-like reactions that exist. And you can see it's really it's all over the map. So anytime you see an abnormality on chest CT in someone who's on one of these drugs, you have to put this on your differential for sure, along with metastatic disease, regular pneumonias, etc. There is a grading system that is out there. For the most part, it's pretty straightforward and I think somewhat useful. Grade 1 and grade 2 are really your very basic disease, probably what you would think about treating as an outpatient. They're not hypoxemic. Grade 1 really is asymptomatic disease. You're just seeing it on a CT scan. Grade 2, they may have mild symptoms and some involvement of a good portion of the lung. Grade 3 are those who you're going to admit to the hospital, severe symptoms, maybe needing oxygen, involving more than just 50% of the lung. And grade 4 are ICU patients, respiratory compromise, may need intubation, and that's really a pretty ominous sign when you see that in these folks. There really isn't a gold standard test for this. You just need a high index of suspicion. You need a CT SAM, obviously, CT scan, a good history, a good exam. You need to rule out infection, and bronchoscopy with BAL and transbronch probably is underutilized to really evaluate these patients. I think the biggest issue is whether it's metastatic disease or an immune complication. They're obviously treated quite differently. And so you really want to know, and I think bronchoscopy often can be the only way to kind of glean those differences. Often it's both, which is even more difficult to learn, deal with. This is, I think, a reasonable approach based on a recent review. If you have someone with new symptoms, you get a CT scan. If there's nothing new on there, you just follow them and maybe repeat the CT scan, assuming the symptoms don't resolve. If there are new lesions and you really want to think about whether this could be an infection, you do think about bronchoscopy in this situation, make sure it's not pulmonary edema, and then treat if you think it's that. But if there is nothing that's clear there, then strong suspicion of drug pneumonitis, then you're going to treat according to the severity grade. As I mentioned, bronchoscopy can certainly be helpful in people who can tolerate that. Anybody with diagnostic uncertainty, potential infection, question metastatic disease. I think some people are out there saying we should be bronching everyone who can tolerate it. We haven't gone that far, but you can really help sometimes in gleaning and know what you're treating, which is always helpful. And the path can be all over the place: cellular interstitial pneumonia, granulomatous inflammation, acute lung injury, organizing pneumonia. But you're really making sure it's not cancer, it's not an infection. And then on occasion, I have bronch people with existing ILDs to see how active their disease is before starting them on a immune checkpoint. If it's really burnt out disease and you don't find a lot of inflammation, I feel a little safer about that than others. How about management for these folks? This is all based on kind of expert opinion right now. Grade 1, you can hold the drug, repeat the CT. If there's improvement, then you can go ahead and restart the drug. If no improvement, then you would start steroids. Grade 2 are almost always started on prednisone. Moderate dose of mg per kilogram per day, and then you can try a moderate taper over 4 to 8 weeks. You also want to consider bronch for these folks. If they're not getting better, then those are folks that you may think about putting them on IV steroids, maybe also antibiotics in that situation, or bronching these patients. And then in the grade 4 diseases, we're adding secondary agents, things like tocilizumab, MMF, IVIG for these folks who have life-threatening disease or unresponsive disease. Steroid courses, generally I do one of 3 things: a short course, about 6 to 8 weeks. Those are I'm trying in the grade 1 to 2 disease. Often the oncologists do this themselves before sending us patients. And very frequently these folks feel better initially, and then the disease comes back, and you need to go to a longer course, either a medium or long course in those situations. For folks with pretty significant disease, I usually do the medium course, so that's a longer sort of 3-month course. Definitely if they're grade 3 or 4, I might do that, or grade 1 and 2 who just haven't responded fully. And then there are folks who just require the 6-month course, like you would do for an interstitial disease, organizing pneumonia, recurrent disease. When you try to taper, those are folks who may need longer course. Certainly a steroid sparing agent, which for the most part I use MMF in those situations. Just a couple of definitions to throw out there for you. You can have recurrent disease, delayed onset, which occurs 3 months after ICI discontinuation. You can have chronic active, chronic inactive disease. Multi-system means it's obviously hitting in multiple spots. But the main things I'd focus on are steroid unresponsive complications. These are folks who really have no benefit from steroids. This happens, and it's obviously pretty ominous, especially with severe disease. Steroid resistance are people who have some benefit but don't fully resolve, and then there are those steroid dependent folks who improve, but anytime you try to taper, get worse again, and really require those longer 6-month courses, often with steroid sparing agents. For people who have really refractory pneumonitis, no improvement after initial treatment, for the most part, what we've been using is IVIG, which seems to have some reasonable data to be used, sometimes tocilizumab, 2 doses of this a week apart. There was data for infliximab, but the results have been really mixed, and there is some idea that you may actually make things worse with that. So the most part, we're not using that for pneumonitis. Sometimes it's used for colitis. So it is still out there, and a lot of patients come in with colitis and pneumonitis on infliximab. And then for more long-term therapy, MMF can be used. And the recent review in BMJ said MMF and IVIG for steroid-resistant pneumonitis was their recommendation, followed by TOSI. The first 2 agents fail. I have to say I've used TOSI really for the severe grade 4 cases up front. Just have had some good results with that, and that's based just on anecdotal evidence. This disease comes back. Interestingly, you can re-challenge these folks. If they've had grade 1 or 2 disease, once you treat them, you can re-challenge, and about 50% of them won't relapse when you re-challenge them with the immune checkpoint inhibitor. So just because you've had a complication from the checkpoint inhibitor doesn't mean you have to be off of it for the rest of your life. And often these folks need this for their tumor therapy, so we manage through them getting this. Things like having worse grades make you more likely to have recurrent disease if you were hospitalized. If the treatment was short, you're more likely to have recurrence in these situations. But you can try it. I'd say most people with grade 3, we wouldn't try it. And certainly if they had grade 4, we wouldn't retry the immunotherapy, and they need to figure out something else. Sometimes we put them on immunosuppression and the immune checkpoint, which seems like a little bit of a push-pull, but hope that you still get some tumor activity in that situation. So just to summarize this, and then we'll move on in the last 5 to 10 minutes to talk about airway disease. Pneumonitis is a common complication, relatively common with immunotherapy. The diagnosis is based on imaging, clinical assessment. There is a grading system. You should consider bronchoscopy for those folks. If detected, consider definitely a hold of therapy, and then treatment with corticosteroids, and more severe disease may require secondary agents. MMF and TOSI is what we've used, as well as IVIG. And then you, of course, can consider re-challenge if the pneumonitis resolves and there wasn't prior severe disease and they need it for their tumor. Very difficult at times to manage these folks because they often they get pneumonitis because their tumor is responding really well, and that's always tough to hold therapy that you know is beneficial for their cancer therapy. All right, let's breeze through some stuff with asthma. I know you just had an intro to this or a discussion of this already, so I'm not going to spend too much time, but I think about asthma as really a reaction to these environmental antigens, or allergic asthma in this case specifically, where for most people you get no recognition or tolerance to these allergens, but in asthma there is an immune reaction and inflammation that results from this. There's a lot on the mechanisms of this. I'll just make a couple points here. This involves both the airway epithelium, antigen-presenting cells like dendritic cells, T cells, mast cells, B cells. So this is a huge response. Asthma can be broken into this allergic phenotype, which is driven by eosinophils, Th2 cells, epithelial-derived cytokines like TSLP, IL-25, IL-33. And then there's this non-eosinophilic asthma, which is a huge need because we don't have that many effective therapies that may be triggered by more pollutants and toxins and infections. IL-33, TSLP, and IL-25 may also be involved here, but there's less of these kind of eosinophils and IL-5 and IL-13 in these non-eosinophilic forms of this, although they can be somewhat involved. We now have, this is just kind of going through all the different therapies that are existed and have been tried in the past. You can see omalizumab here. It's kind of the end stage effector, blocking IgE. And as you move up the sort of inflammatory cascade here, you have dupilumab blocking the activities of IL-4 and IL-13, mepolizumab and benralizumab blocking IL-5 activity on eosinophils, and then the epithelial-derived cytokines, which are the most recent approved in TSLP, tezepelumab, blocking these cytokines derived from epithelium that activate dendritic cells and sort of stimulate the T cell response. And other drugs that have been tried that are unhelpful, like anti-IL-23, anti-IL-17, which is really effective for things like psoriasis, just have not had effects. Anti-IL-13, interestingly, although dupilumab is effective, have been a little more controversial on whether they really are effective in asthma. They work really well for atopic dermatitis, interestingly, whereas TSLP does not in that situation. So lots of nuances to this that we're still sort of learning and gleaning, and a lot of my research really works on this. I'll just show this as because it's an interesting story. Anti-TSLP was developed by AstraZeneca. It was tried in allergic dermatitis and failed, and so it was shelved. And then this group in Canada said, well, we're kind of interested in this. Let's look at this in asthma and convince the company to give them some. And they just took 31 mild asthmatics, gave them tezepelumab, and looked at allergen challenges. So this is where they nebulized cat or house dust mite for subjects and saw what happened. And you can see here that on the initial time where they nebulized and gave a challenge here, you can see eosinophils jump in the sputum, FeNO jumps after that, and I don't have lung function here, but, or do I have it right here? Yeah, you can see here lung function drops in this sort of situation. They then started tezepelumab and then gave allergen challenges at day 42 and 84, and you can see that blunts the response to allergen. When they gave it, it blunts that bump in eosinophils and blunts the bump in the FeNO that occurs when you do this. And this was proof of concept that if you gave anti-TSLP, you prevented airway inflammation. And they then went on, the other groups that went on to study this with 2 different large trials. And really the important thing about TSLP is there seems to be activity in folks who don't have eosinophilic asthma. So it works whether your eosinophil count is less than 250 or greater than 250. I have to say the real world experience is it's not quite as effective for these folks, but seems to reduce exacerbations, improves FeNO and lung function in these, and is certainly effective in folks with eosinophilic/allergic asthma. And those folks, you can see here the eosinophil count. If it's greater than 450, it's really effective in reducing exacerbations, but even if folks with less than 150, there seems to be an effect there. So it is the one drug you can use for non-eosinophilic asthma. Other therapies that are on the docket may come as anti-IL-33, another epithelial-derived cytokine. This has been studied. What's interesting about this study is they used it in combination with dupilumab, thinking that would be even more effective. But in fact, when they compared it, it works just as well as dupilumab, but in combination seems to be worse. So again, something we don't quite understand about the immunology, why targeting 2 unrelated cytokines, which you think would be better, at least just as good, actually you fight against each other and may work against it. Just for time, I'll skip ahead. This just showing not everything works as we plan here. This is the anti-IL-23 therapy that seemed to be, was thinking would work in both eosinophilic and non-eosinophilic asthma. And in fact, people on this therapy, not only did it not work, but they actually did worse with this. And this is sometimes used in psoriasis. So if you do have patients with psoriasis and asthma, this is a drug they should not be on because it does make your asthma worse. What about COPD? Well, there were several trials that looked at COPD with mepolizumab and benralizumab that did not show benefit, and kind of felt like they were looking at the eosinophilic form of COPD, which is 30–40% of COPD have a prominent eosinophil component. And so this was maybe thought to be non-productive in COPD, but then 2 trials in dupilumab came out, the Boreas trial, which showed a 30% reduction in exacerbations, improved lung function, improved symptoms. This was really, I think pretty exciting for those of us who treat COPD. For folks, it was followed up by the Notice trial back in last year, which also confirmed these effects in people with eosinophilic COPD. You get reduced exacerbations, improvement in lung function. And so this was approved last year for COPD and has been effective for my patients for sure. And this is hot off the press, just released yesterday. I added it in, but I thought it was relevant. MEPO now in COPD, if you first don't succeed, try again. And in fact, a group did a study of 804 patients who were on triple therapy with blood EOs greater than 300, and mepolizumab was effective. It reduced exacerbations by about 20%. Interestingly, they did not improve symptoms or lung function in this study, but adverse events were similar. So there is now a second choice in theory that may go up. Mepolizumab was close the first time, was almost approved. So I think with this study, they probably will be able to get it approved for COPD in addition. And finally, I'll just add in the last minute here that in EGPA, there's data to support the use of mepolizumab and benralizumab also, non-inferior in these cases. And in fact, benralizumab seems to work better. So if you do have patient with EGPA, Fasenra or benralizumab is an effective therapy. So the take-home points: main function of the immune system is organ homeostasis. Lung is one of the four mucosal immune sites, extensive environmental and systemic exposures. Immunotherapy involves treating disease via manipulation of the immune response, and immunotherapies have had dramatic therapeutic benefits: lung cancer, asthma, COPD, also EGPA, but you do have to keep in mind immune-related adverse events, and it's a new group of drug-induced complications. All right, thank you. I'll end there.